Good morning, everybody. Thank you, Diva-ben and the organizers for inviting me. I'll talk about role of interventional radiology in thyroid pathologies. So what is the role of intervention? Starting from diagnostic to therapeutic. FNAC, we all know that is a basic standard procedure for diagnosis in benign or malignant thyroid pathologies. Angioembolization and ablation. These are both therapeutic. Coming to interventional radiology, diagnostic, apart from FNAC, is core needle biopsy. We take true cut biopsies in some patients where FNAC has been negative. Treatment is divided in two parts. Vascular treatment is embolization for benign, and for malignancy it is ablation. For papillary sometimes we use, and also for benign nodule ablation is done. Ablation is again thermal and ethanol induced. We'll talk in detail. So multidisciplinary team is always ideal. It is complementary to have surgeons, endocrinologists and intervention radiologists to take care of the thyroid pathology. These are thyroids where patient on ultrasound, if the nodule is solid, very hypoechoic, taller than wide, and there is extrathyroidal extension with punctate echogenic foci, these are very suspicious nodules. FNAC or FNAB, it is gold standard and first line of diagnosis. Nodules less than 5 mm, we should follow up with ultrasound. Nodules of 5 to 10 mm with suspicious findings that we discussed prior, we should closely observe. And FNAC should be done if there is a suspicious lymph node, extrathyroidal enlargement or family history of thyroid cancer. Again, ultrasound findings are divided into three types: low, moderate and high risk. More than 10 mm lesion and high risk findings on ultrasound, we should FNAC it. More than 20 mm and moderate risk, or more than 20 mm with low risk if there is an increased lesion size. So follow-up images are essential. Follow-up reports we should always see. So how an FNAC is done, you keep the patient supine with neck in hyperextension, keep a pillow under the shoulder, painting and draping, always done under local anesthesia, with a 25 gauge spinal needle. That is best for FNAC of the thyroid nodules. We do a back and forth movement. Negative aspiration very rarely we use, and manual compression after removing the needle. So there are papers whether you should use negative aspiration or not. If we use negative aspiration, the chances of blood in the biopsies are FNAC is more, and the chances of negative FNAC is high. Non-representative sample is high. So always try not to use a negative aspiration. So needle visualization, parallel or perpendicular. Parallel is better. We can visualize the entire needle track, and we can see whether we are away from the carotids, IJV or not. So this is just a schematic diagram. How to make slides, again this is very important. Fill syringe with empty syringe with air and push the contents in on the slides, and fix it with 95% alcohol, and not to use excessive pressure between glass slides, otherwise there will be crush artifacts. Core needle biopsy, FNAC is around 70% sensitive. So core needle biopsy is done when the FNAC is negative and still the suspicion of malignancy is high. So needle biopsy is 100% specific and a positive predictive value, with 97.5% sensitive that required surgery, and 98.6 for negative predictive value for benign nodules. We use, so 25 gauge needle is used for FNAC and 18 gauge needle is used for true cut biopsy. So generally true cut biopsies, we use semi-automatic guns, and the outer needle is 17 gauge and the inner gun is 18 gauge, where at least 3 samples are taken. We do in such a way that we get the capsule also, so that we do not miss anything. Manual compression is ideal. We see small hematomas after biopsies, but they are generally treated with manual compression only. This is Bethesda system where one is non-diagnostic and two is benign. So we generally treat benign multinodular goiters with ablation or embolization. We don't treat follicular neoplasm with intervention radiology treatments. In malignancy, in some cases that I will show, we use ablation for papillary thyroid carcinoma. Coming to treatments, cystic nodules, aspiration is the first line of treatment, just simple aspiration. But again, it will recur 95% of the times because the wall cavity, the wall epithelium will again secrete the fluid. So aspiration is used once for reducing the size, reducing the compressive symptoms, and it also confirms the benign nature because you can send the fluid for cytology. So this is a cystic nodule with some solid component. Patient wanted aspiration, we aspirated and sent it. So it reduces symptoms, but once it recurs, we can treat with ethanol injection. So for benign cystic lesion recurring after aspiration, PEI is ideal. Ethanol 99% is injected in the cavity. So how much ethanol is injected? If we aspirate 20 ml of cystic fluid, we can inject 7 to 10 cc of ethanol and give manual compression for few minutes. It causes reactive fibrosis in the epithelial wall. It destroys the epithelial wall and stops reaccumulation of fluid. It is highly successful when the nodule is only cystic. With some solid component, the success rate reduces, but again it can be combined with ablation where we ablate the solid nodule part and rest of it is treated by ethanol injection. Coming to ablation, microwave and RF ablation, trans-ischemic approach, single puncture is used, again done under ultrasound guidance, under local anesthesia. Give tumescent anesthesia for the surrounding tissues, ablate with a moving shot technique, that is ideal. So our hand-eye coordination is very important for coordination. We should be very much comfortable with ultrasound. Hydrodissection we see for the risky areas, danger triangle, recurrent danger nerve, vagus nerve, carotid, IJV, and do a good hydrodissection, that is very important. Then the ablation. Indications of ablation: benign symptomatic nodules, presence of compressive symptoms, or for cosmetic reasons. For malignancy, advanced age, patient preference, T1A, T1B, papillary thyroid CA, unifocal disease, central location in the gland. These are the indications. Advantages of ablation: there is reduction in nodule volume, around 30 to 50% reduction in a month. In 6 months, it would be more, and in a year, it would be around 70%. Avoidance of scars, no need for thyroid hormone supplementation. Patient walks out of the clinic in the evening if we have done the procedure in the morning. So this is done in the local anesthesia. So very less morbidity. Coming to the hydrodissection techniques, the skin puncture and the strap muscles, we inject diluted local anesthesia, diluted lignocaine. It aims to protect the cervical sympathetic ganglion and the vagus nerve, and it also helps for pain relief. But for the danger triangle, we use saline or dextrose, and for posterior to isthmus in the peritracheal area, we don't give local anesthesia. So as we need to see whether we are damaging the nerve because of our heat or not. So if the voice change happens, we stop. So for hydrodissection posteriorly, saline or D5 is used. Sometimes we use up to 100 ml of NS so that the hydrodissection is adequate, and we have to supplement it because saline, it is absorbed faster than colloids. So sometimes colloids are used or saline is preferred. If we are in the deepest part of the nodule with the trans-ischemic approach, sometimes after inserting the electrode or after inserting the ablating needle, We give upward or the anterior pressure. So there is a space between the recurrent laryngeal nerve, the danger triangle, trachea, and our nodule, so that the less chances of heat damage to the tissues. We also tell the patient to do to speak during the procedure or to do simple E, so that we know whether the vocal cord movements are present or not. Thyroid tissue is devoid of sensory innervation. So any sensation of pain, you stop ablation, inject, give more hydrodissection, and then again start the procedure, or change the place of your electrode. If we see the electrode is somewhere at the level of capsule, so we take it back little bit. So that's why general anesthesia or sedation is avoided for the procedure. Two ablating modalities, RFA and microwave. RFA is used less now. Microwave is a better modality. It creates spherical ablation. It creates a better ablation, and it has less heat sink effect or no heat sink effect. The frequencies range between 900 to 2500 megahertz, and there is oscillation of the polar water molecules and generation of heat. So a 17 gauge electrode, internally cooled, the electrode is connected with a cooled saline, and it moves within the electrode so that the electrode works properly. And the active tip is around 3 mm. It causes homogeneous ablation. So it's a moving shot technique. You continuously move the electrode. Once there is a small micro bubble of air, you see on the ultrasound around the tip, you take it back, ablate it, take it back, ablate it. So around 5 to 10 seconds, you ablate 5 to 10 mm of area and continuously move the electrode. Again, this is better, different from the lever ablation, where you keep the needle stabilized. Again, this is to prevent heat-related damage to the surrounding structures. For smaller nodules, 5 minutes of microwave ablation time is enough. For larger nodules, sometimes you do a technique like the lever ablation, you keep it for 5 minutes, the ablation zone would be around 3 centimeter, and you do a multiple overlapping ablation zone. But for larger nodules, more than 20 ml volume, embolization is better. This we have talked. If the patient should be fully awake during the procedure so as to evaluate for the laryngeal nerve function in between, intermittently. Sometimes a small vessel is punctured, there is hematoma, you stop the procedure, compress for 5 to 10 minutes, the hematoma would not increase, and you again restart the procedure. Recurrent laryngeal nerve is situated between the trachea and the thyroid gland in the upper neck near the cricothyroid joint. At the mid cervical trachea and below, the danger triangle concept is less reliable, and now can run 1 to 2 centimeter lateral to the tracheoesophageal groove. In the lower cervical level, entire posterior capsule should be and we should give very good hydrodissection. Applicator position should remain stable even when the patient talks, and that is how transisthmic approach helps. How to do ablation? You see for the artery and the vein on ultrasound and the Doppler. Direct puncture the artery and the surrounding area so that the artery gets clotted and there is reduces heat sink effect. So less power is needed. So power anyway we keep between 30-20 watts. Marginal venous ablation. So ablate the artery and the vein, the blood flow stops, and we can achieve very good ablation. How to manage complications? Posteriorly in the thyroid nodule, you keep lower power near critical structures. Hydrodissection is very important. If there is hemorrhage or bleed, you stop the procedure and you can compress, or you directly ablate the bleeding artery first so that there is no blood flow in the artery. Lidocaine toxicity, tinnitus and agitation, it goes away in half an hour. If there is vocal hoarseness, you can see on ultrasound the vocal cord is not moving, stop the procedure, inject 30 to 40 cc of cold dextrose, D5, not DNS, D5 in the posterior danger triangle. You can give steroids also. Post procedure, avoid physical strenuous activity, check neck puncture site, and there will be pain, some sort of soreness for few days. Hyperthyroid symptoms are common for first few months. Uh, do an ultrasound at 1, 3, 6, 12 months and see for nodule regrowth. Repeat ablation is done generally after 6 months, not before that. Need for multidisciplinary team is for large retrosternal nodules with visceral compression. If a large nodule, you ablate the anterior and the mid part so that they get necrosed, there is size reduction. Posterior part comes anterior after 3 to 6 months, and then you can have. This was a real case. There was a thyroid swelling, good vascularity. We ablated. This is our needle. And post ablation, there is just peripheral vascularity with reduced size. So this is very good for cosmetic purpose. Another case, ablation volume was more than 30-40 cc, but they didn't want to take the risk of stroke in embolization. There is some very minimal, less than 1%, but risk of stroke. So they chose for an repeated ablation. So this is after ablation, very less vascularity in the thyroid nodule and good size reduction. So this is an American Thyroid Association nodule ablation statement. So surgical societies have accepted thyroid ablation as a good treatment modality and as an alternative in benign cases. There are also guidelines for malignancy in PT1A, PT1B. So these are alternative treatment strategies. Recently done case, 80-year-old male operated open total thyroidectomy with bilateral robotic neck dissection. Supraclavicular node came and FNSE was medullary CA thyroid, good vascularity. This is IJV. And after proper hydrodissection, this was ablated. This is our needle. This is how the air foci are seen. This is after ablation. So this case was done just 3-4 days back, and let's see the result. Embolization, as I mentioned, done for volume more than 20 cc, less than 20. You take femoral puncture, embolize superior and inferior thyroid arteries, just once last, and superior thyroid artery, and this is inferior thyroid. Okay, thank you.
Thank you, Dr. Rozil.
You said cystic, you inject alcohol only. You don't do microwave. Just aspirate the fluid and do microwave.
Yeah, purely cystic, yes. With solid nodule, we use ablation and alcohol both. But for purely cystic, I have never ablated the wall, just only the wall. No, I have never
like
done
that.
it.
We just aspirate and we ablate the wall and then solid.
So no ethanol.
No ethanol.
Okay.
Because mixing that, I am not sure whether we should mix it.
So I've done for cystic aspirate.